trying to ablate and destroy the microcarcinoma with RFA makes perfect sense. Maybe we can do better than active surveillance, but we don't need to resort to taking out a whole thyroid or even a lobe. A lot of these things are pioneered outside the United States, mostly in Korea and Brazil. That has a lot to do with our FDA. And a lot of these groups have large numbers and have shown success, so we follow suit. All of this is an evolution, and surgery and medicine is a living, breathing profession that has to change to progress. I came with a case explaining why this was good for not only the patients, but for the health system, and it has been.
Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today's guest is Dr. David Goldenberg, a head and neck surgical oncologist, currently professor and chair of the Department of Otolaryngology, Head and Neck Surgery at Penn State Health and Penn State College of Medicine. Dr. Goldenberg combines a busy surgical practice with teaching and research. His clinical practice includes head and neck cancers, thyroid cancers and parathyroid disease, and radiofrequency ablation of thyroid nodules. His clinical research focus is on outcomes and etiology of the rise in incidence of thyroid cancer. Dr. Goldenberg is also an accomplished and prolific author of over 230 journal articles, 35 book chapters, and 7 books in the field of head and neck and thyroid oncology and surgery. His latest book, entitled Head and Neck Endocrine Surgery, a comprehensive textbook surgical and video atlas, is the most comprehensive textbook to date on the subject of thyroid and parathyroid surgery. Dr. Goldenberg, welcome to the podcast.
Jen, thank you very much for having me on this podcast. I appreciate it.
First of all, I would love for the audience to get to know you a little bit. So tell us about your background and how you kind of got into being an otolaryngologist.
So I trained in medical school in Israel, and very early on, I wanted to be a head and neck surgeon, and I had really no interest in ears, noses, or throats. I just wanted to be a head and neck surgical oncologist. And I decided to do a residency in otolaryngology head and neck surgery to attain that goal. And then I came from Israel to the United States in 2002 and did a 3-year fellowship, 1 year doing basic science in the lab and 2 clinical years at Johns Hopkins doing nothing but head and neck surgery and oncology, including a large thyroid practice as well. I stayed at Hopkins for a very short while as an attending, and then I came to Penn State about almost 19 years ago to become the director of head and neck surgery. And as time progressed, I formed a department of otolaryngology in what was a division of surgery, and I am now the chair of the Department of Otolaryngology at Penn State in Hershey, Pennsylvania.
So as a head and neck surgeon, you are doing surgeries, obviously, and RFA, for those people who are not familiar, let's just give a brief summary. RFA is a non-surgical procedure that you can use to treat thyroid nodules by inserting this probe into the thyroid gland, and the tip of the probe heats up the nodule and essentially kills it. So as a surgeon, what on earth gave you this idea of adopting a non-surgical technique?
Well, the way you presented it there is different than the way I look at it. I am first and foremost a physician. I'm not a provider. My job is to offer the patient the most reasonable, effective technique that I can for a given problem. Mm-hmm. Sometimes it's surgery. Sometimes it's observation and nothing. And now that radiofrequency ablation is being used for thyroid nodules, it was the natural progression of how to care for these patients. It's just one more tool. You typically say, oh, I'm a surgeon, I'm not going to do some other intervention. Sometimes as a surgeon, what I do is observe. Certainly that's not surgery, but I have many patients who I just watch their thyroid nodule, biopsy it sometimes not, to make sure that it's not malignant, it's not causing compressive symptoms, or it's not secreting hormone. Right. So I don't really see it as surgical, non-surgical. I see it as a very effective tool in the appropriate candidate. And I'm always happy to learn something new and to offer it if I think it's reasonable.
I love that perspective. I think that is exactly right. Having that idea of it being a tool in the toolbox. For those patients who are wanting to pursue this as a possibility, what would the process be of them determining candidacy?
Since I've been offering this, and in the age that we are in, that information is readily available, I've been doing this now for one of the early adopters, certainly the earliest adopter in the Commonwealth of Pennsylvania. I've had a deluge of patients, and that's mostly from people looking it up and saying, I want to do this. So a lot of patients will self-select, and they'll come to my door and they'll say, I want RFA. And like it or not, they're going to have a discussion with me. First and foremost, I have to understand from the patient what it is that's bothering them. I have many patients who will come in and want RFA for a thyroid nodule that is both tiny, non-suspicious, non-secreting, and not bothering them. Well, because I have a thyroid nodule. And I say, so what? You and a gazillion other women have thyroid nodules. So what? Is it bothering you? No. So we first of all have to know what's bothering you. Once we've come to that, and if I think that RFA would be a useful tool to help that given patient, then we have to, I insist on a biopsy to rule out malignancy. There are some, if you look at the guidelines from all over the world, they're similar, but in some ways they're dissimilar, whether, earlier on, they were insisting on 2 biopsies. Some of the countries said no. For myself, what I want is a reliable biopsy. So if the patient comes with a biopsy that was done within the last 6 months or so, but I'm not sure of the reliability, I don't know the pathologist, it's not from my institution, then I probably will get another biopsy. And it's less about I have 2 of them now, and more about, I want to make sure that I am comfortable that benign is actually benign. Okay. So once we have a benign biopsy that I am comfortable with, and we know that we're not dealing with a malignancy in error, because we do RFA for certain malignancies, but I'm saying a malignancy in error, then I have a conversation with the patient about the risk, benefits, and alternatives. And I mean the risk, benefits, and alternatives. So the risks of RFA, what they can anticipate. They have to understand that surgical intervention it's fixed now. Tomorrow it will be fixed. RFA is not. RFA, you have to be patient. It takes time for the debris that you cause by the thermal injury to be evacuated by the body. So they have to understand that.
Right.
And the alternatives, you can not do this if you don't want to, and you can have surgery, and you can have just observation. My recommendation is A, B, and C, and then we move forward. And that's usually my selection criteria. If the patient is complaining of compressive symptoms, I also have to be convinced that those compressive symptoms are attributable to the thyroid nodule. The reason being, a lot of patients come in with a vague sensation of something in their throat. It's overwhelmingly caused by laryngeal reflux, incredibly common. And while it's something I can fix, and there's many a patient who will leave with both RFA and medication for reflux, my office, if need be, I want to make sure that I'm convinced that the thyroid nodule is what's causing the problem in their compressive symptoms. The reason being because if you do RFA and that's not going to fix it, you can have a very disappointed patient.
Of course.
And someone comes in with a 1 centimeter nodule in the periphery of the thyroid gland, and they're saying they're having a problem swallowing. And I usually say to them outright, you do have a problem swallowing, and I believe you, and will help you, fix it, but it's not your thyroid nodule. Right. And while I'm happy to do RFA on you, it will not fix that particular problem. So there's many patients that I convince not to get RFA because I just don't think it will help them.
We see patients a lot who are scared, in our community. They come to the community, they're very scared about this thyroid nodule, and they start complaining of those kinds of symptoms. And I think sometimes and I know patients don't like to hear this because it seems almost insulting, but it's an anxiety, and however, if you've got a huge thyroid nodule and you feel like you've got a golf ball stuck in your throat, that's a totally different situation, which was actually what I experienced.
You'll have patients who will come and they'll say, well, what am I supposed to feel? And I'll say, I'm not going to tell you.
Yeah.
I'm not going to give you ideas. But, usually these conversations, at least in my office, are incredibly cordial. I try and educate the patient. Like I said, I'm there to help. That's my job.
Mm-hmm.
The only thing that I won't do is I won't do what I think is, I will not allow a patient to dictate care that I think is wrong. If a patient insists on A and I don't think A is right for them, then I'll say, we've reached an impasse. Try someone else. And it actually doesn't really happen that often.
Mm-hmm.
Every now and you'll have a patient who'll come in and they will demand a certain treatment, whether it be surgery and so on and so forth. And I'm far too long in the tooth to allow that to sway my decision.
I think that's important to mention. I'm glad you brought that up because we, in almost 5 years of our community being in existence, we've seen a few patients before who have had thyroid nodules, which we're going to talk about cancer in just a moment, that were inappropriate for treatment. Maybe they had a 4-centimeter thyroid cancer nodule. And would that ever be a possibility to be treated with RFA? Because what we are always telling them is that you're probably not going to find anyone will treat that.
Well, I have a frank discussion, and I am willing to push the envelope as long as I'm not going to hurt the patient.
Right,
How they say, right? First, do no harm.
Mm-hmm.
And as we learn this, everyone in this and our community, the RFA doctors who are doing this, whether it's endocrinologists, endocrine surgeons, head and neck surgeons, radiologists, etc., are pushing the envelope a little bit because we're learning. So, I started off when I started with this with very large nodules, and the results were good, but not as great as they would be with the optimal of 2 centimeters. That being said, we are doing parts of larger nodules to help people avoid surgery. Like, for instance, started doing it where patients who have a goiter that's going down in their chest and they're not, usually I would have to have the chest split to get to some of these, and patients do not usually enjoy that. And therefore, for these older patients, sometimes we will ablate the top portion of the nodule in hopes that when it shrinks, it will pull up the portion from the chest. But this is all new stuff.
Mm-hmm.
I mean, we are learning as we go along. We also have a community. We also discuss these things.
Mm-hmm.
You're in your important role, many of the players in the United States and abroad, and we talk all the time. And as long as we're doing the right thing, the patients are informed, we're doing this safely. I think that over time, the size of the nodule, will be less of an issue. Sometimes, I'll say to the patient up front, they come in a 4 or 5 centimeter nodule, say, I'll do this for you, but it may take 2 times. Mm-hmm. I've had patients who after once have said, what, it shrunk enough, I feel great. That's another thing that we had to teach ourselves is the ultrasound is not the patient, okay? And I say that because I've had patients who've come in for their 6-month checkup. I'm disappointed in the way it looks, and the patient is over the moon. They're just happy as a clam. And guess what? It's not about me, and it's not about the ultrasound. It's about the patient. Mm-hmm. Patient feels better. They like the way it looks now. The compression's gone. That's wonderful.
Size is important. Patients understanding, in those larger nodules, it may take 2 applications or more. That was actually my experience. In these benign nodules, it's not necessarily a limiting factor what the size of the nodule is. But I want to talk about cancer because we have seen some patients, when you mentioned about some insistence from the patients about, I'm going to have this no matter what. We've seen some patients who have really large cancers who want RFA. And unfortunately, we have to explain to them, no one is likely to be willing to treat the large size of your cancer. So let's talk about, when is it appropriate to treat a thyroid cancer with RFA?
Great question. To clarify, I'm just going to have to expand a little bit. Thyroid cancer comes in 4 flavors. Papillary thyroid cancer, which is the overwhelming majority of thyroid cancers, and that is fortuitous because the cure rate with surgery, not with RFA, the cure rate with surgery and perhaps radioiodine in younger women, which is the population which is most affected, 95 to 98%. So the cure rate is excellent if treated appropriately. Mm-hmm. There are 3 other types of cancer: follicular thyroid cancer, which has a slightly less optimal prognosis, but also pretty good. And then there's medullary thyroid cancer and anaplastic thyroid cancers, which are aggressive, and we're not even talking about them. So let's go back. We're talking mostly about papillary thyroid cancer. And papillary thyroid cancer will start sometimes as what we call a microcarcinoma. Microcarcinoma, by definition, is less than 1 centimeter. Why the cutoff? Well, there needs to be a cutoff, and that's what it is. Mm-hmm. So 0.9 millimeters, microcarcinoma, 1 centimeter and above, not. And first we started saying, well, we're going to treat microcarcinomas because they're very unlikely to spread with RFA. Now, I've been doing this for a long time, and I've certainly seen microcarcinomas that have spread all over the place. So it's not that they can't spread. Mm. There is a group of patients who are undergoing what's known as active surveillance. Active surveillance is another word for close observation, meaning they get ultrasounds every so often. And if the microcarcinoma is, then they're sent for surgery or some other treatment if they agree to it. So I guess the thought was, well, why don't we try and ablate these since we're going to watch them anyway? Mm-hmm. That's not the same group of people, but that's the rationale. You have a microcarcinoma, it's unlikely to spread. You're going to continue to watch it. And I tell every patient with a papillary thyroid cancer, every patient, lifelong surveillance. I say that because most of these patients are very young or young. Young and old is a sliding scale, as you know, but you're going to be watched for the rest of your life. Mm-hmm. And I've seen people recur 32 years out.
Wow.
So, I tell them that. I said, long after I'm either in an old age home or gone, you're going to have to find yourself someone else to watch you, but you need forever. Not a big deal, once a year, once every second year. But if you think about that, then trying to ablate and destroy the microcarcinoma with RFA makes perfect sense. Maybe we can do better than active surveillance, but we don't need to resort to taking out a whole thyroid or even a lobe. Mm-hmm. So that's the rationale. It makes sense. Like many things in not only RFA, but in at least in interventional medicine, maybe in non-interventional medicine, but in surgery, a lot of these things are pioneered outside the United States, mostly in Korea and Brazil. Mm-hmm. That has a lot to do with our FDA, but I'm not going to get into that. And, a lot of these groups have large numbers and have shown success. So we follow suit. So that's the rationale and that's the explanation. If someone comes in with bilateral, both lobes are involved with thyroid cancer, they already have metastases to the neck, no, RFA is not appropriate for them.
Right.
If it's large cancer, I personally don't think it's appropriate. The problem is papillary thyroid cancer has a tendency to spread through the lymphatics. And one of the things we can do when we do surgery is the pathologist can look at the tumor and say, I already see spread into the lymphatics on a microscopic level, or a lymph node came out and it already has papillary thyroid cancer. Mm-hmm. That will buy the patient radioactive iodine. Well, we can't know that if we do RFA. And like I said at the very beginning, I've seen patients who have microcarcinoma who have spread to the neck with a microcarcinoma. So if you take the worst case scenario, you see someone with a microcarcinoma, the cancer is already in the lymphatics. You go and you ablate the tiny nodule. You pat yourself on the back. The patient pats him or herself on the back. And then 6 months later, they pop up a lymph node because it was already out of the box by the time you ablated it. I would agree to do RFA only in a responsible patient who I know is going to come back and be watched. I don't want to be responsible for hurting the patient. Does that make sense?
Absolutely. And I think most patients would agree with that because we do see a fair number of patients with thyroid cancer who have a lot of anxiety about what you were just describing. having RFA and then it didn't actually solve the problem. And so it's very important, as you were saying, that you select the right patient as far as the characteristics of their cancer and if they're going to be responsible to follow up. For criteria of thyroid cancer, it's got to be papillary
and micro
and
as far
small.
as I'm sure there are people who may not agree and they'll 1.1. That's what my criteria at this point in time. If you and I have a conversation in 3-4 years, it may be different.
Of course.
Because all of this is an evolution, and surgery and medicine is a living, breathing profession that has to change to progress.
Absolutely. And progression is, if we weren't changing and we weren't adopting new techniques, then we wouldn't be having this conversation today. I'd like to take a moment to thank the sponsor of today's episode, RGS Healthcare. RGS Healthcare has been a leading medical imaging equipment distributor for more than a decade. RGS is known not only for recommending personalized medical equipment solutions, but also for offering continuous support to ensure success. One thing RGS is particularly known for is unparalleled physician training and on-site staff support. They are the only medical equipment supplier known for accompanying their doctors to exclusive, specialized thyroid RFA physician training on live patients proctored by leading world experts. If you'd like to learn more about RGS Healthcare, please visit their website, rgshealthcare.com. A heartfelt thank you goes out to RGS Healthcare for supporting this channel. Now, back to the podcast. I want to circle back with that in mind to when you first adopted RFA. During the pandemic was when you were going through the process of training and doing all of this startup. So kind of give us some background on that.
I was just abroad in an airport outside the United States, and there were these little tiles on the floor that said social distancing, and they were spread apart like 6 feet, and they were all cracked and worn. No one bothered to take them off. We did not have the luxury or the misfortune, it depends on how you look at it, of shutting down. Because I think shutting down was a misfortune to a lot of people, and we didn't have the luxury. You know, it's interesting that otolaryngologists were amongst the first people to get very, very sick with COVID because we were up in patients' grill, if you were, when they had the virus. And you know what happens? You know, it started in Wuhan, then it went to Milan, then it went to England, then it came to us. And I had otolaryngology colleagues in London who were on ventilators before it started coming here en masse. So we knew something bad was happening, and we continued to work. We just did. We continued to work. RFA became an option at that time, and I couldn't go to Rio de Janeiro to get trained. So I asked my colleague and friend, Dr. Ralph Tufano, who was one of my mentors at Hopkins when I was a fellow, if we could fly him. Actually, he was in Baltimore at the time. We'd drive him up, and we were both wearing masks, and our patient were wearing masks, and he proctored me. And, you know, pandemic or not, we started doing it, and we got, yeah, that's right. I forget that was, thanks for reminding me. That's when we started it. And it was a non-issue. We all wore masks and we did our job, and it went well.
It was a time. It was quite the crazy time because we had so many patients who were anxious if they were going to be able to have RFA, and a lot of patients didn't get to because they had to wait during all of that. I actually had my second RFA procedure quite literally the last day that procedures were done at the University of Virginia before everything stopped. You know, I was just very thankful and grateful. I had lots of gratitude that it worked out. So now fast forward from your training experience during the pandemic to now you're actually training other physicians.
Well, I was, my fellow Dr. Elizabeth Cottrell, very, very talented young surgeon who I was fortunate to train back in 2017. Beth wanted to be involved, and she was amazing. Traveled to Philly and got to see Beth and watched her do her first couple of procedures. Obviously, we all do courses and we train and we watch videos and we do that, but we proctor each other. And I proctored her, and she did a phenomenal job. And, she's now the second person doing it in the Commonwealth. I don't know if there are more. You probably know better than me. I don't really keep tabs on that. But, and we train each other. And then I was down in Brazil teaching and training people down there. And down there, they do it in the operating room, not like us who do it in clinic. And that's another interesting thing. A lot of this has to do with the health systems that are behind it. Believe it or not, and patients may not realize it, but the health system that you belong to, it's not just the insurance company, which is its own discussion, but the health system helps dictate how things are done for good or for bad. So yeah, I train people in Brazil, and I probably will be back there. And we're doing an RFA course in Hershey, June 1st and 2nd. We did it last year, end of May, incredibly successful. We cap it at 25 participants so that everyone, has personal teaching training. We have, the who's who of RFA in the head and neck surgery world. We have Ralph Tufano. We have John Russell from Hopkins. We have Erivaldo Volpi from Sao Paulo, and Leonardo Rangel from Rio de Janeiro, and myself as instructors. And it's a cadaver course, hands-on, half a day of lectures to be followed by 2 days of hands-on course. And we're very excited. It was incredibly well received. And, we have new people doing this because of people's willingness to travel around the world and teach. Kind of nice.
That is so exciting. One of the things patients are always asking is there anyone available now in my state, in my city? And that list that we maintain of physicians across the world is always growing. For anyone watching this who wants to know what I'm talking about, our community, Save Your Thyroid, has a website, saveyourthyroid.org, where we maintain lists of physicians in the U.S. and physicians across the globe who offer RFA and other non-surgical techniques that are now coming available. I'm excited to know, who ends up adopting this after your course this summer. Thanks so much for watching this episode. I hope you're enjoying it. This podcast requires a lot of my time, effort, and resources, but it is a labor of love. If you'd like to directly support my work here, you can do so in 2 different ways. You can purchase products from one of my affiliate brands, or if you would prefer to make a donation directly to the podcast, you can do that as well. Links to do either are located in the description below. Every dollar contributed goes right back into this podcast. Additionally, if you'd like to support the Save Your Thyroid patient advocacy community, which is working toward becoming a nonprofit organization, you can donate via our fiscal sponsor, THYCA, Thyroid Cancer Survivors Association. Simply visit thyca.org, click donate, and designate your gift for SYT. To learn more about us and the work we do, please visit saveyourthyroid.org. If you have any questions about any of this, don't hesitate to email me at saveyourthyroid@gmail.com. Any way you choose to support the podcast or the SYT community is sincerely appreciated. Your generous contribution keeps this work going and helps us to help more patients like me and you. Thank you so much for watching, and now back to the podcast. You're in academia. I would love for you to share this today about what's different in your perspective on RFA versus surgery because of your experience in academia versus someone who maybe has a different experience.
Well, I've never been in private practice, so I can't speak to that end. I chose an academic career because of something that you and I already touched on. Medicine is an art, and I feel a deep obligation to pass our knowledge on to the next generation. So I am very interested in teaching and in research, and in addition to my clinical job. Head and neck cancer surgery really needs to be done is easier or better facilitated in academic institution because it needs multidisciplinary care. It's not just about me. We need our radiation oncologists, our medical oncologists, endocrinologists, the people who give radioiodine, our nuclear medicine, nurses, swallowing therapy. The list goes on and on. And if you're in a private practice alone, it's very hard to coordinate that. So for me, this was the natural way. When it comes to RFA specifically, well, you said it. It's a new technique. Even as I get older, it's incredibly exciting to embrace something new and to use it and to progress with it and to be able to offer it to the patients and to be able to say, patients, this is not for you, but I can still give you something else and do a great job by you. Again, I can't say what it would be like in private practice. I don't know what it's like to, I can tell you that in academia, we're usually big health systems, and convincing the I'm going to say this kindly, convincing the administrative powers that be why this is important, and how this helps not only the patients, but the health system at large can be challenging at times. I mean, when I was teaching in Brazil, I was teaching a couple of Americans who came down. Some were in private practice, some were in health systems. The patient has to understand, how do you adopt a new technology? It's not just, okay, I want to do RFA, I'm going to do RFA. No, you need an RFA machine, you need an ultrasound machine, you need permission, you need credentialing, you need privileges, you need administrative buy-in. And those things are not simple. And in some places, they're harder than others. And a lot of the questions that I was asked by other doctors, Americans, because like I said, every health system is different, every country is different, by Americans, how did you adopt this from the standpoint of your institution?
Right.
I digress a little bit, but I'm in an academic institution. I've been here for a long time. It was not difficult for me, but I came with a case explaining why this was good for not only the patients, but for the health system. And it has been. I mean, I have patients coming to me. Since I was the only person in the Commonwealth, I had patients coming from New York. I had patients coming from Maryland. And since I'm licensed in both of those states, I was able to offer them follow-up via telehealth, so they didn't have to schlep down every time they needed to be seen. So it just worked out very, very good for the patients, but also for the health system. I know a lot of doctors will come to my course and they will want to do this, and they'll be gung-ho, and then they'll go home and they'll have the air taken out of their tires because the administration says, I don't want to buy the machine, I don't want to do this, I don't know if this is to the point, but I'm just babbling.
I think that's a great point, Dr. Goldenberg, and it's something that I've heard a lot over the last several years. Is my perspective as a patient. I'm not your average patient because I interact with both sides, and so I could see it from both sides, the patient side and the physician side, more so than maybe the average patient. I hope that doesn't sound like egotistical, but
no, not at all.
I hear what you're saying. I've heard a lot of physicians say, I want to do this. I really want to do this, but I can't get this or this or this or this taken care of.
And you can't get administrative buy-in.
Yeah. It's not just about, do you want to do it? It's, can you make all of the blocks line up? And unfortunately, a lot of patients don't understand that. And so my goal is to always help them understand, it's not that your doctor just doesn't want to do it or doesn't have the opinion that it's valid as a treatment option, or that it's even beneficial. They have all of these barriers and obstacles to overcome. So I'm really glad that you mentioned that. I'm glad that you didn't have any great deal of difficulty bringing it on, but unfortunately that has been a problem for a lot of doctors across the board. And I'm glad to see that it's spreading in prevalence, because that means, I guess, a lot of these doctors who are having issues, maybe the community growth is maybe knocking down those.
Right. Yes, I think that's well said. There's a community pressure on the administration of healthcare, but this is the way any new surgery is. I mean, I'm old enough to remember multiple surgeries that have gone through the exact same thing. This is not unique. And the progression is actually interesting, the way it happens. But so from my standpoint, in academics, I get to study it, I get to teach it, and that's one of the advantages of being in academics are those issues. And that's the way I guess I view it. Yeah. Another thing that needs to be mentioned, RFA of the thyroid. So, I tell patients that everything that's important from the head that needs to get to the body has to run through the neck, right? So it's like a bottleneck of a highway of really important stuff. And the reason I say this is that not everyone should be doing this. You want to choose someone who's done a lot of these, just like any surgery. I mean, if you want your appendix out, don't come to me. It's been 30 some odd years, right? If you want your thyroid out, I'm your man. That's what I do. Same with RFA. So you want to make sure that the person who, from the doctor's standpoint, the doctor has to be an excellent interventional thyroidologist. You have to have excellent command of not only the ultrasound and the surrounding anatomical structures, which are critical,
Right.
carotid artery, recurrent laryngeal nerve, multiple others, but you have to be an excellent interventional thyroidologist, meaning you have to have really good control of that needle, because you can really hurt someone if you don't. So, I would say that your patients, I think, you're doing a wonderful service by, making the list available who does this. But I think that the patient should be doing their homework
Yes.
as to choosing someone who does. Just saying, it's not the profession. You're an endocrinologist, you're a surgeon. It's more about, you do a lot of these,
Right.
and you've been doing it for a while.
Mm-hmm.
Yeah, just want to bring that up.
That's so important. I'm really glad you mentioned that. And that's one of the best things about our community, is that patients have the ability to ask one another, do you know Dr. So-and-so? Are they very experienced? And patients will speak up. Patients will unashamedly share, yeah, I had a great experience, or not so great. I mean, we very rarely do we see anyone really just, complain. The vast majority of patients say, even if it wasn't the most stellar experience, they'll say, it was great. I wish these things could have been better, but we now know. And so it's important. It's exactly what you were saying. It's important that you have a high volume surgeon if you're going to have surgery. It's important, if you have RFA or any other thermal ablation, you have a high volume physician, because you don't want to be, that doctor's first attempt. We know that the heat from the tip of the probe can cause injury in the neck, and if it's not placed properly. And so that's actually a question we had from a patient in our community, is if you want to mention, are there any short or long-term complications about that current that's going from the probe into the patient's body? And maybe if a patient watching this is unfamiliar, you have an electrical current going through the tip of the needle and exiting the body at the grounding pads, which are typically on the legs. So talk about that a little bit.
Well, I'm not a electrophysiologist. All I know is the current causes heat,
Mm-hmm.
and the fact that it has a grounding pad, it means you're not going to get electrocuted.
Okay.
All right, so, which is the fear. So the current is not like, it's not like radiation or electrons or protons, which are going to cause long-term DNA damage,
Mm-hmm.
if that's the question.
Mm-hmm.
Because radiation, the way radiation works, for instance, it causes damage to the DNA of the cancer cells. That's why you do it.
Mm-hmm.
This is not that. This causes heat.
Mm-hmm.
And thermal ablation, which is the type I do, causes heat using radio waves. There's microwave, there's laser, there's all kinds of things. But what they do is they cause heat.
Mm-hmm.
So it's not the waves, it's the heat. And the heat is going to destroy the tissue within a certain radius of the tip of the needle, depending on the heat source and the type of needle you're using. You have to know, I have to know that very well, so that I can keep the tip of the needle away from any critical structures that I can hurt. And the way you do that is you have to have control of that tip of the needle. You must see the tip of the needle before you turn on the current. And we do.
Mm-hmm.
No needle tip, no current.
Mm-hmm.
Reposition until you can see it. And that's how you keep the patient safe.
Mm-hmm.
Now, you have to have a mastery of the anatomy. You have to understand what you're looking at.
Mm-hmm.
Because, the thyroid gland sits on its outside, the lateral side. You have the carotid sheath, which houses the carotid artery and the jugular vein, and you see it very, very clearly. And in between them is the vagus nerve, which is very, very important.
Mm-hmm.
And on the opposite side, that is towards the middle, you have the trachea, that is the airway, which can be damaged. Mm-hmm. And at the lower portion of that, where you have the esophagus, and where the two of those two meet, you have the recurrent laryngeal nerve, which gives motor innervation to your larynx or voice box on that side. Mm-hmm. And if you turn on the heat in that area, which we call the danger triangle, you can make the patient hoarse for life. And if they're a singer, they won't sing anymore.
Right.
And so you have to be aware of these things. And to avoid it, All right. And if possible, not always possible, but if possible, sometimes we'll use a dextrose solution, a solution of sugar, to what we call hydrodissect. What that means is we inject this solution in between the nodule and a critical structure to actually lift it off and make a liquid cushion, if you will, between the nodule and a critical structure. So we have techniques, but it all starts with making sure you know what you're looking at and you know where you are. Now, I personally, I have the husband, or I say the husband because it's usually a woman, but not always, or the wife. They're allowed in the room if they want to watch during the procedure.
Oh,
That's
really?
the way I do it. Well, first I ask permission of the patient because ultimately the decision on privacy is that of the patient. And sometimes I'll say, can my husband or wife be in there? And then I'll say to the husband or wife, do you want to be in there? I'll say no or yes. And then I will ask them, you're not going to faint, right? Because there may be some blood.
Yeah.
And oh, no. And I've not had anyone.
That's good.
And if they want to, and there's a screen and they can watch, and they'll, afterwards, how do you know where you are? I say, well, because to me, this is a picture. This is, like an illustration. But again, going back, it's critical that you're aware of where the lesion is and keeping it safe.
Definitely. Yeah, that ultrasound image that you're looking at during the ablation, the first time I got to see an actual patient undergo an ablation and I saw the tissue turning white, because ultrasound, for those of us who are lay people who don't understand ultrasound, it's very hard to understand what you're looking at. But, it's a lot of gray and, blobs and whatnot. But when you see the needle, as you were saying, you have to see that tip of the needle, and you can see it once you realize what you're looking for. You can see, oh, there's this line, there's the tip of the needle. And then when the ablation starts and you see that tissue turning white, that is so intriguing. So I think if I were in that situation again, I think my husband, because he's an engineer, I think he would find that really interesting to be able to watch that. I think that's cool that you do that with your patients. Talk really quickly about treating a toxic thyroid nodule. Is there anything different that you have to deal with in ablating those nodules?
Yeah, so toxic thyroid nodule, much like cancer, the ablation has to be more thorough for it to do its job, because you have a nodule that's secreting. If you get rid of most of it, part of it may continue to secrete. So it may take more than one time, and the nodule, and or if it's not an optimal area where you can ablate safely, it may not be as feasible. These are very uncommon, but patients will come in with them every now and again. It has to be a more thorough ablation. And it's more about the overwhelming destruction of that nodule for it to stop pumping out thyroid hormone.
Well, we are coming towards the end of our time, but I just wanted to ask you one last question. You wrote an article that you shared with me the last time we spoke about the term provider. And this is something that when I read this paper, it kind of opened my eyes, because I have had to kind of adjust my thinking here, because we have referred to doctors as providers, not knowing any better. Share with the audience why this is maybe not the best idea.
Well, everyone in a healthcare team is incredibly important, but we are unique and different. Not only do I believe that the term provider is demeaning towards all of us, I believe it is purposefully demeaning. It is a generic term lumped together by, let's call it the powers that be, insurance companies, I'm not really sure, to make us all the same. And we're not.
Right.
I resent the term, as do many physicians. So I wrote this article. I looked at the history of the term, the history of the words, and this is not the first time that this has been used. And like I said, I think it's a purposefully generic term. I told you from the very beginning, medicine is an art. We work very, very hard to do our part, whether we're physician's assistants, PAs, speech language pathologists, nurse practitioners, physicians, and everyone brings something very important to the table, and they deserve to be termed as such, You do not have lawyer providers. You do not have CEO providers, correct?
Mm-hmm.
And there's no reason in the world that the physician should be termed. Whenever someone does this in my department, I politely explain that to them. That's why I wrote this short article. I've sent it out to multiple people. I don't allow that in my department for the reasons that I explained. Anyone who wants to can look it up on Medline. I published it maybe 6 months ago in the Southern Journal of Medicine. I think it's called Words Matter, the use of the dubious term provider.
Yes, I actually have it pulled up right here. I think it's a great article, Dr. Goldenberg, and I appreciate you sharing it with me because I think you and I were having a conversation one day and I inadvertently used the term provider, and it never even occurred to me that it would be something so insulting until I read your paper. And now I make a concerted effort to not use the term, although I will admit that it may slip from time to time, just not, intentionally. I think where I slip up the most is in using the word, this doctor, this physician is a provider of RFA. Would that be an appropriate thing to say, do you think, or would it be better to just say this is an RFA physician?
This physician offers RFA as one of their therapy models.
Okay.
One of their treatment options.
Yeah. Okay.
I mean, provide is not a dirty word.
Sure.
Provide is not a dirty word. And that's where it came from. Oh, you're providing the service. Mm-hmm. But at the end of the day, these are my patients. These are not my customers.
Yes. Couldn't agree more.
And I am a physician purposefully to help patients. And all of these words, if you look them up, there's a reason that they're the way they are.
Words matter. Yeah. They really do.
They do.
I appreciate you sharing it. I'll put that link to that in the description video so patients can read that. I think that they will find that very enlightening. Dr. Goldenberg, it's been an absolute pleasure chatting with you today. Thank you so much for joining me. I hope that you have a wonderful turnout at your training course in June.
Always a pleasure to talk to you, Jen. And, let me know if I can be of any help.
Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community. Save your thyroid. You can also find me on social media and Substack under the media handle It's Me, Jen Again. Never forget to educate yourself and be your own advocate and save your thyroid.